So in relation to our NMC code, we're asked within the guidance, the sample acceptance guidance, that if we do get a rejected sample, that we're to reflect on that. We can use that within our revalidation. So I've just pulled out some parts of the code that would support that reflection if you were to receive a rejected sample. So 14.1, so to act immediately to put right the situation if someone's suffered actual harm or for any reason or an incident has happened which had potential for harm. Explain fully and promptly what has happened, including the likely effects, and apologise to the person affected where appropriate, their advocate. Document all these events formally and take further action. Escalate if appropriate so that they can be dealt with quickly. Take measures to reduce as far as possible the likelihood of mistakes, near misses, harm, and the effects of harm if it takes place. And Sarah's shared on many occasions, we've done sort of top tips that you can implement in practice, which would help reduce those rejections. Take account of current evidence, knowledge and developments in reducing mistakes and the effects of them and the impact of human factors and system failures. Take all reasonable personal precautions necessary to avoid any potential health risk to colleagues, people receiving care and the public. Keep your knowledge and skills up to date and taking part with appropriate regular learning. So that would be your 3 yearly updates. And currently we're just devising a video to support sample takers when they've had a rejected sample. So that will be sort of a key part of learning and support going forward. And make sure that any treatment, assistance of care for which you're responsible for is delivered without undue delay. So that's making sure that we get women back in if they're due for that repeat screen. And I just wanted to finish off with really that the year of the nurse and midwife was 2020. And the National Screening Manager, Ruth Stubbs, she spoke to the World Health Organization about the importance of nurses providing an efficient screening service to patients in England. And it was acknowledged that England's known for its high quality standards, with nurses playing a vital role in delivering and maintaining these standards. So it's a plea really for us to continue to work together to ensure that processes and fail-safe procedures are in place to make rejected samples a never event across Greater Manchester. So I want to thank you for your ongoing support in delivering such a high standard screening programme for our population. And it's a plea really to make sure that you've got those fail-safes and those processes in practice. We can again share the top tips, but it would just be to care really. So to check the patient details on arrival, to attach an ID label to the vial, ensuring patient checks the details prior to leaving, review the date of the previous sample, and the expiry date of the vial should always be checked prior to sample collection. And if you do those things, it will hopefully support that reduction of rejections. Thanks, Sarah.
We do know that the majority of samples are taken and are processed fine, and they do have the correct label and they are done in date. But I think the 1,500 women, that's a lot of women who are affected by mistakes that were avoidable. And also that's a lot of pressure on primary care to have to get appointments, to have repeat appointments for all those women. So we just want to do whatever we can to support you and put things in place that help you reduce those really. So I just wanted to finish with a few general programme updates that we get queries about quite a lot. So the cervical screening administration system, you'll be aware that there was quite a lot of comms last year about this new system that will be replacing Open Exeter, but unfortunately the launch has been delayed. We don't have a date yet as to when that will come in, but we will keep you updated through these forums and through our normal email communications when we do have a new date for that. So in the meantime, please do continue to use Open Exeter. It is still functioning and you still should be used for PNLs and to check any histories. You might be aware that there's some self-sampling evaluations and pilots happening at the moment. So there's a trial happening in London, which is contacting women who are non-responders to see if they'd be interested in doing a self-sample. And there's also the labs are taking part in a validation trial, which is having a look at self-taken samples and comparing them to clinician-taken samples to see if they come out with the same result. So I know there's a couple of practices in Greater Manchester that are involved in that. So thank you if that's you for supporting that research. So we're hoping that these bits of research will be completed in the next 12 months. and then we'll get further advice on whether there's suitable to become part of the national screening programme. So at the moment, although there's a lot of work going on, and we're not expecting to see self-sampling being part of the programme for the next couple of years. We do know that some people are purchasing self-sampling privately. So if you do have patients who do that, just be aware that you can't add that result onto their national screening programme, their national screening records. They will still be called for their national cervical screening when they're due. And there has been some guidance about that in the primary care newsletter in the last couple of weeks, so you may have seen it. And then finally, you'll be aware that in Scotland and Wales, they've changed the screening interval for the 25 to 49 cohort to 5 years. We are expecting that to happen in England. However, again, we don't have any confirmed timeline for it. So we'll keep you updated as and when that happens, really. So that's everything from us. If you do have any questions, please do put them in the chat and we'll answer them. And thank you again for all your work on the cervical screening programme, because it's, as Sarah said, it's a world-leading programme, and I think it's one that everyone should be really proud of taking part in. So thank you for your role in that.
Oh, thanks, Sarah. So we've just got one question, I think, in the chat. Elaine from Trafford has had a rejection sample from a smear that was taken in a hub on Saturday and Sundays because the external staff have no access to open Exeter. So what should she do? She tries and checks before they are booked in.
Yeah, so we'd encourage people to try and check. Can they get access to open Exeter, Sarah, at the hubs, you know?
I would need to go back and have a look at our policy. I've picked that up alone, and I'll message you separately outside of the meeting.
Yeah, certainly the new system, everyone should be able to get access to that. But until that's in place, we do ask for the practice to then recall the woman just as a fail-safe to make sure that she's been contacted.
Thanks, Sarah. So Chloe from Greenbank has said, should we be keeping a list of all smears taken by us?
Yeah, there's a requirement that every sample taker should audit the samples. So yeah, a list. And you could do that on an Excel spreadsheet on your desktop, or you could have a list that you keep in a locked drawer that you record the samples taken, and then you check that you've received a result for those. Or your practice could set that search up and run that search on a monthly basis to ensure that every sample taker who's taken a sample in the practice has received a result for that sample submitted.
Thanks, Sarah. So another question from, sorry, the questions are coming in so fast I can't read them. Let me just move it back up. I still see girls who have been vaccinated against HPV with the virus needing yearly recalls or being seen at colposcopy concerning 3 yearly recalls. I'm not really sure if...
I think the evidence that the national team have gone up with, which I can share the national screening committees, is that if someone has that smear that's HPV negative, then it's safe for them to then have a 5-yearly interval. So that's what the evidence has shown, and certainly in Scotland and Wales, that's what's happening. But I can dig out where the research is from that and share that.
Thanks, Sarah. Last one. I have a 68-year-old whose annual repeat was due March. She hasn't been called from gynae. She attended here, but I said it would need to be by gynae. Who takes responsibility for gynae not calling patients after 12 months? How long can a 68-year-old expect to continue annually tests for HPV?
I think, Sarah, if you email me outside of this meeting with the patient details, I can follow that up with the unit. It's not something I can answer today. I'd have to see the history.
Thanks, Sarah. Another one, is there any guidance on making and storing spreadsheets for data protection?
So they would need to be kept in a locked drawer. If they're on your personal drive within your computer at work on your desktop, then you would be the only person that had access to that. It's around not losing any patient details or taking patient details out of the practice. It might be safer to ask the practice manager to set that search up, or your cytology clinical lead within the practice.
Yeah, I think most computer systems have the facility to pull a list of patients, and that's probably the easiest way of doing it.
Yeah, and last one. So Anne-Marie from Conway Road had this patient came for smear 6 weeks early following loop excision, has been called for. However, gynae later said due on the actual date or after. So she came for a smear 6 weeks early following loop excision. Is that right, Anne-Marie? Am I saying that right?
Yeah, she had a loop excision done and she was on a 6-month recall. And on the gynae letter, it said due either on that date that was exactly the 6 months or after. And she came 6 weeks early. As she'd been called for, she received a letter.
And was that rejected?
I gave her the decision to looking at the notes, it looked like she could have it up to 3 months early, which seemed a lot when gynae specifically said on the letter from that day onwards. So we've gone with what gynae recommended.
I think the guidance is the 12-month ones can be done 3 months early. I'm not sure about the 6-month ones, but again, if you let us know the full details, we can check with the guidance in the gynae unit. Okay. I'll put our generic email in the chat, so if anyone does have any concerns, you can email us about it.
Okay, thank you.
I think that's all the questions. Yeah. Thanks, Leslie. Over to you.
Yeah, no, thanks very much. That's not, sorry, Leslie, that's not the end of questions. We've got 2 people with hands up. Oh, right, okay, because we've got to move on. We're over a bit of time now. If there's anything that could be sent to Sarah and Sarah via email.
Or if they put the questions in the chat, we can send them to Sarah's.
Yeah.
Yeah, so Kaylee and Denise, if you can pop your questions in the chat, then we'll get a response to you within the next 15 minutes.
Thanks, ladies. Thanks, Sarah, or both Sarahs, for that update. That's some really important there on sample errors. 500, that's a lot of ladies inconvenienced and a lot that have had to come back for a repeat smear. So thank you for sharing the both local and national guidance on what we can do to make that a never event, and to remind us of our NMC code of conduct and where we stand as a health professional. So thank you so much for that, and I'm sure the tips and the remarks that you've given will be taken back to practice today, and we'll all look seriously at that again. Thank you for your time. Thanks very
Leslie.
much.
Thank you.
So we'll move on now because we have got a busy schedule today. I'd like to introduce to you Greater Manchester's Diabetes Programme, and I'll introduce Ewan at first, and then I'm sure Ewan, you'll introduce your team as you go along. So thank you for coming today, Ewan.
Thanks very much, Leslie. I'll share my screen. We've got some slides to work through, and then, excuse me, I will pass over to colleagues on the call. Krista Williams is a member of my team, and Lisa Stack, and I think Anne Goff as well are joining us from GP Excellence, who we're working with as well. So if you bear with me just for a moment. Can you all see those slides okay?
Yes, thank you.
Thank you.
Okay. Lisa and Krista, as I get to your elements, please just prompt me to move to the next slide. Just a quick intro, first of all, really. The Strategic Clinical Network has a number of networks which comprise the overall body, and it's part of the Greater Manchester Health and Social Care Partnership. So there's a couple of intro slides in. We will share the slides after as reference. I don't propose to go through each of these in a lot of detail. We very much are led by clinicians. So we have clinical leads from nursing, secondary care, primary care, and a range of other settings. We do a lot of networking and collaboration, and we try and identify and reflect on unwarranted variation in particular. With regards to diabetes, I've just flashed up there a screen showing the overall excuse me, governance model that currently exists. As I'm sure you're aware, we're moving towards the development of the Integrated Care Board in GM. Last year, the Diabetes Board was established, which is in the middle of that diagram. And you can see how it links into the Diabetes Clinical Network, who a number of you may have attended over the years. The board agreed last year to establish a number of steering groups. They're listed there. Some of those are up and running, and Krista will be talking about one of those later. Others are still emerging. Now, this is an important part of the governance structure because historically, transformation funding for diabetes has not flowed through to Greater Manchester because we've been in the devolution model. That's changing. All the funding for diabetes is being wrapped up into one payment for each ICS area, and that will be just over 2 million for GM this year. And that the board have agreed a model whereby that will flow down and work through the steering groups primarily. And there's a number of deliverables which we're tasked with working on by the national team, and the Diabetes Board put its draft diabetes plan back into the Northwest region and NHS England for approval on the 29th of April. So again, that's there for reference if anyone needs to look at it. We're going to talk specifically about structured education. Now, this is publicly available data from the NDA, that's the National Dashboard, which all of you can access if you want. You can see there that for the CCGs in Greater Manchester, the referral rates for diabetes structured education are quite high, typically up around 67 to 80%. Now, that's a figure which is reflected back to us by the national team and is also linked into QOF. However, when you look at the attendance rates for diabetes structured education, they're much, much lower, typically anything from 0 to 15%. Now, with near on 200,000 people living in GM with diabetes, that's quite important and quite concerning. So the Structured Education Steering Group has looked at a number of areas where this could be approved, where work could be done. And again, this is a driver diagram to look at a range of different change ideas, and it's not an exhaustive list. There may well be other work that comes through. In particular, what we've done is engage with GP Excellence, and we're looking at developing a programme to train primary care nursing staff in particular. So Lisa is leading on that from GP Excellence. I'm going to hand over to her now to talk through that element of the plan. Lisa.
Hi, thanks, Ewan. I hope people can hear me okay. Could you just go to the next slide, please, Ewan? Thanks very much. So for people who don't know me, hi, I'm Lisa Stapp, Programme Director for Primary Care Board. And I'm joined this afternoon with Anne Goff, who's our Programme Manager for GP Excellence, who I'm sure many of you do know. And we haven't got many slides, we've only got about 3 or 4 slides, but we just wanted to give you a bit of an overview of the training offer that we've been commissioned to provide for structured diabetes education. The delivery model, some of the training modalities, but ideally what we want to do is learn from yourselves what works best for you in terms of the approach and flexibility of the education that would be most appealing for you. So if you could go to the next slide, please, Ewan. Sorry, this is just an overview of the training offer. So as Ewan's mentioned, the Strategic Clinical Network commissioned GP Excellence to deliver the diabetes training package for primary care nurses across GM. And the aim of that really is to increase the uptake of diabetes structured education and support practice nurses and potentially community nurses to develop the knowledge, skills, capability to deliver a much more personalised care approach to patients with diabetes through having a blended approach to education. So the aim of the programme, it'll be CPD accredited and supported by the Personalised Care Institute. And it'll also connect with the GM training passport as well. So ensuring that you can keep an ongoing record of those CPD points, which will contribute towards revalidation. So I think next slide, please, Ewan. we go to the next slide, Ewan? Sorry, thanks. So I'll hand over to Anne, who's just going to talk a little bit about the proposed model and training methods. And then we're just going to do a short exercise with you using the polling function on Teams to get some of your thoughts back about how this might work best for yourselves. So Anne, I'll introduce you. I think you might be on mute, Anne.
Right. Can everybody hear me? Okay. Anne Goff, GP Excellence Programme Manager. Thanks for that, Lisa. So as Lisa has just described, we've been commissioned to deliver a personalised care diabetes training programme. And really our initial thoughts are that we're looking at covering 4 modules, which will include shared decision making, motivational interviewing, creating high quality person-centered care, and read code training. So just to give a little bit more background on those, what we're hoping to do is set up a series of webinars with complementary podcasts and e-learning modules. So we're hoping to make it as flexible as possible, and we're looking to have a launch event, a launch webinar at the end of June or July. But before we go on to the next slide, which will kind of hopefully get your feedback, we are working in collaboration with the Personalised Care Institute, and so we're looking at really a dedicated e-learning platform that you will access either through GP Excellence or directly through the Personalised Care Institute. That will take you to the e-learning modules. We're looking to have a series of interactive webinars, some podcasts, and where practical, some face-to-face if you feel that may be appropriate, or certainly some face-to-face peer support for those who may think they require it. And a potential next stage could be train the trainer, but very much looking at a blended model that will support different learning styles and hopefully apply as much flexibility as possible, so we get maximum sign up to the course. So as I say, those are the 4 core modules that we're looking at, and we're looking at a blend of webinars followed up by e-learning modules and podcasts. So if we could go to the next slide, please, Ewan, and if Claire could start to launch the first poll. We've got a series of questions here that we're hoping you'll be able to answer. We'll collate the information, and hopefully that will give us the intelligence to understand what your preferred options are. We'll then come back to speak to Leslie and some of the workforce leads to understand what might be the best way forward. So although these are our initial ideas, we want to make it, it's your programme, and we want to make it fit for you. So if you could possibly just answer the first poll on your preferred learning style and submit your answers, if that's possible.
Sorry, I can only see my own screen because I'm still sharing. Is that okay, or do I need to stop sharing?
Okay, sorry, Claire. Do we need to do something different?
No, people are responding, and the
responding.
response rate's moving up. So no, that's fine.
Thank you.
Great, thanks.
Sorry, I haven't used this functionality before. It's all very new to me. So,
if anybody's missed it, it will appear in the chat.
And I understand it's tried and tested. So people submitting, Claire, because I can't see anybody.
Yes, we've had 68 responses. I'll give it another minute, and then I'll launch the next one.
Okay, that's perfect. Thank you. Okay, so this one is around, and I'm sure there's no right answer to this. Are there any days in the week that are better for you? If it's e-learning or podcasts, then obviously that's in your own time. But we are hoping to put on some educational webinars, which we hope people will attend. And obviously, if you could indicate if there are any days that are absolute no-nos, and I'm expecting maybe Mondays is one of those. But if there are any best days, then please indicate in the poll, and we'll work to our schedule around those. Okay, Tuesday seems to be coming up as a reasonable one. Okay, so is there any particular time of day that works for nurses? Morning, lunchtime, afternoon, evening, bearing in mind that we're not intending to make any of these sessions particularly long. So if you could indicate, and you can indicate more than one option if you've got a couple that work for you. So any times in the day that are better. Okay, so just building on that, and as I say, we're hoping to make everything as flexible as possible. What would be the ideal length, duration of a webinar session? 1 hour, 2 hours? We are looking at just one of the areas that might be a half day. But if that's an absolute no, then we'd have to have a rethink on that. So if you could indicate whether there's good times, bad times, and whether it's a possibility to kind of fit in the others if there were some half days. But that's not our preference. We are looking to make them as sort of reasonable length possible for you to be able to attend. But the motivational interviewing, what we've found on that one so far is it does depend on the it does feel like that's best delivered over a half day or a full day session. So certainly around motivational interviewing, I think we'd really like to look at sort of 2 half days or a full day if possible, because that particular topic lends itself to that duration of learning. But I suspect the other areas we would be able to fit something nicely within a 1-2 hour session, followed up by e-learning and podcasts. But certainly for that bit, I think it's a bit more in depth. Something coming up there, plenty of notice. We'll need at least 6 weeks. Yeah, that's great. So on this one, It's really about who in your practice do you think, who in your practice is primarily responsible for the delivery of diabetes care, and who do you think would benefit the most from the training? So that may be a combination. We appreciate that it's not always the practice nurse that does all the diabetes care, and that you're working as part of multidisciplinary teams. So if you could indicate who primarily delivers the training, and then who are the best candidates to benefit most from the training. I think there's one that looks a bit cut off there, Claire, that the last one is community nurse or other. That looks a little bit cut off on my screen. So we've got practice nurse, nurse associate, healthcare assistant, community nurse, other. That's great, thank you. Are people still submitting, Claire?
Yeah, a couple more coming through.
Perfect, thank you. I'm very impressed with polls. I haven't used it before. It's very good.
It's all in the preparation.
Absolutely, and thank you very much, Claire. You've put a lot of work into this for us. Thank you.
Okay, I think it's stopped now.
Perfect. So, just our closing slide to thank you for listening to us. We really hope that this is of interest to you. It's a really important programme, and obviously we've just listened to, you know, we've just heard from you and how important it is, and how much personalised care fits with the whole of the diabetes programme. We'd love to hear from you if you've got any ideas. We'd love for you obviously to join the course once we've finalised it. We will be looking to Leslie and other practice nurse leads, or you know, CCG nurse leads, to help us to understand that we're on the right track with the training. But thank you very much for your time today. Lisa, have you anything more to add to that?
Echo what you said, Anne, really. Just thanks very much to everybody, particularly people who took part in the poll. It's the first time I've used it as well. It's quite impressive, isn't it? And I think it's given us a real good insight, actually, because I think we made some assumptions, didn't we, thinking what days would be best and what would be best. And actually, I've seen some surprising replies. So that will help us, I think, in terms of designing this programme. I mean, I know you're all incredibly busy, which is why we're trying to make it as flexible as possible and blended as possible so that you can partake in it. But I noticed in the chat, plenty of notices needed for you to book time off. If anybody can put in the chat how much notice you would need, I'd personally find that really helpful. I can see somebody's mentioned you often hear 2 to 3 weeks in advance, which isn't long enough. So if anybody wants to put anything in the chat, that will help us, because we are just designing still at the moment, and we want to get it as right as we can, so it meets the needs, and you can partake in it 6 weeks-ish. Okay, at least. Well, that's helpful. But yeah, thanks very much, and please get in touch with us if you want to talk about it, and keep your eyes open for any more communications coming out once we know a little bit more about it to share with you. Thanks.
Thank you.
Thanks, Lisa, and thanks, Anne. That's really useful. just before we move on, I showed a slide earlier about the attendance rates at structured education for GM. Now the slides that will be shared do actually have some additional slides in them. So there's one for each CCG. So you can see how that breaks down by CCG. And I'll show you at the end, if you want to, how to access that information, because you can drill down to PCN and indeed down to each practice level to see all the data on diabetes structured education. But just before we move on, did anyone have any sort of burning questions they wanted to ask about education generally, or for Lisa or Anne? And again, I can only see my own screen because I'm sharing slides, so I'll need someone to tell me if there's questions.
Don't see any hands up, Ewan.
No. Okay, that's great. I'll move on. We do a range of work and get involved in a range of projects and improvement work that the strategic clinical networks. And something we've been working on for some time is Diabetes My Way, which has a website element that provides self-help support and a wide range of resources. There is accredited digital structured education available there. When I say digital, I mean that's something that one person can interact with when they want and where they want via a computer or a laptop or a tablet. Obviously, there's been face-to-face education for some time, and all of that stopped during COVID. But there's also a personal patient dashboard, which is linked up to GP clinical systems like EMIS, so the patient can see their own diabetes data. Now, I won't run the video just now, but there's a link to a video in the slides, so you can get a bit more information on that. We've struggled with, I don't think it's any secret, we've struggled with IG at certain stages and also with the impact of COVID. But we now have a system in place which has agreed that practices using EMIS can sign up to what's called the bulk data extract. Historically, we've had to ask GPs to activate detailed coded records so that patients can access this. This now isn't necessary if practices want to and are able to sign up to EMIS, and we can now provide additional support to actually do some of the admin work behind that through our provider, My Way Digital Health. If practices are interested in that, or if you hear about this, there's a data sharing agreement in place which has been approved across GM by all CCGs, and all the practice needs to do is sign up to that and activate EMIS bulk, and that functionality already exists within EMIS. And then they need to inform their patients that this service is available. Now, that element there is one of the elements that we can provide support with through My Way Digital Health. So there's contact details there for Mark at My Way who can support this. And we found that offering this level of support, putting EMIS bulk in place, has made a huge difference. You can see there how registrations were sort of bobbing along at a relatively low level. Last month, they've absolutely shot up, and that's the direction they're going now in terms of number of patients that are registering for Diabetes My Way each month. So just wanted to highlight that we've got that additional functionality. A lot of you may have heard of Diabetes My Way, but if you see anything or you're asked about activating EMIS bulk or the data sharing agreement, we just wanted to give you a bit of background information, because we see enabling patient self-management, engaging patients with their own data so that they understand that, linking it to personalised recommendations, and providing access to structured education and a wide range of other resources is a key way to sort of support patients and reduce the burden on primary care. So really just wanted to highlight that and really sort of get the message out that we'd like you to really promote that to patients at any point that you get the opportunity to do that. What I'm going to do now is hand over to a colleague of mine, Krista Williams, and we're going to talk about Healthier You, and then we'll have time for some more questions and discussion on any of these aspects once Krista's finished. Krista.
Thanks, Ewan. Good afternoon, everyone. I'm so pleased that there's so many people on the call and that we've been given this opportunity to talk to you about our programme. As you can see from the discussions and the presentation so far from Ewan, we are involved in quite a lot of different projects. So I lead on a number of projects, and one is around the National Diabetes Prevention Programme, and the public know it as Healthier You. Some of you will also probably know it as Healthier You. So it's a national programme and it's free to us. At the moment, we will have 14,900 places available for your patients on the programme annually over the next 3 years. So it's a behaviour change programme, and there's two elements. There's a group-based, now face-to-face, we did go remote for a little while, programme, and there's also a digital one-to-one programme with access to a health coach. We run the courses in various community languages. So I think that's quite of interest to a lot of people. The fact that people can go on a behavioural change programme and actually speak in a language and hear in a language that they feel comfortable with. So Healthy You, in reality, it's a general health and wellbeing programme, but this has been designed to prevent people who either have NDH, in other words, their HbA1c values are between 42 and 47.9, or because they've had gestational diabetes at any time, but they've been in normal range in the last year. The main referral route at the moment is through primary care, and the best type of referral is a direct referral. So on your practice systems, you will see in the NDPP folder a number of documents, including that referral form. But we also have other ways that we are working with primary care, including sending out bulk letters or bulk opt-out text messages as a way to mop up and to make sure that we invite all of your patients that are eligible to join the programme. So we've got a video for you. It's an animation that Adam, my colleague, and I have produced, and Ewan is going to hit the play button. So just relax for about 5 minutes and you'll be able to see all about the programme and how you can make referrals. Thanks, Ewan.
Welcome to a short presentation about the NHS Diabetes Prevention Programme. My name is James Hyder. I'm a GP and the Diabetes Prevention Clinical Lead for Greater Manchester. I'm here to tell you all about the Healthier You programme. You helps people likely to develop type 2 diabetes to reduce their risk, and it is delivered in many different languages, including Urdu, Punjabi, Gujarati and Polish. It is delivered by Xyla's trained coaches and dietitians. Healthier You will support users to eat a healthier diet, get more active and also to lose weight. It is usually delivered in a group session close to the GP practice. Although while we are socially distancing, these sessions are being delivered by conference calls and videos. There is also a digital service delivered by Aviva, accessed by phone or online. These users speak to their coach and access resources to support them to meet their goals. Referring into the service is really very easy. So far, your practice may well have sent out letters inviting all those at risk to join into the programme. The referrals, though, can also be made using a direct referral form on your own practice system. An alert will let you know when one of your patients is eligible for a referral. The practice staff can find these direct referral forms in the NDPP folder, and simply completing this and emailing it to Xyla will allow the support team to contact those referred to book them onto the programme. You'll get regular emails updating you of their progress. The patients who are eligible for the service, if they can meet the following criteria. The patient is 18 years old and over. They have an HbA1c between 42 and 47, or a fasting plasma glucose between 5.5 and 6.9 during the last 24 months. The patient may be a woman with a past diagnosis of gestational diabetes. All patients need to be registered by a GP practice in Greater Manchester, not be pregnant, and not be on an end-of-life pathway. Those people who have attended the course so far have had positive results. On average, they have reduced their HbA1c by 2 units and reduced their weight by 3.3 kilograms. This is going to result in less people developing diabetes, and therefore we're going to have healthier patients with less practice visits, reduced demand for long-term condition management, and reduced prescribing costs. There are extra benefits for your practice from referring into Healthier You, as under the new Weight Management Enhanced service, you will get paid for the referrals you make, as well as also getting the QOF points for performing an annual non-diabetic hyperglycemia review. We've had great feedback from people who've attended. Dorothy from Oldham attended Healthier You and said, "My waist has reduced by 4 inches and my weight has reduced by 1 stone 7 pounds. I feel like I have my freedom back. I would definitely recommend the programme to others. It has helped me so much." Healthier You has primary care engagement officers. These have been recruited to provide tailored support to individual practices to increase the sign-up into the programme. To take up the offer, please contact Rebecca Murray at Xyla.
Thanks, Ewan. Going to stop sharing that now. That's brilliant. Thank you. So you'll have seen from the animation that I think it provides quite a bit of information. What I can tell you is that this programme is being evaluated for the whole country by Manchester University, and over a 2-year period they did actually prevent, but the people that went on the programme, 18,000 people were prevented from going on to develop type 2 diabetes. And I think that is absolutely amazing. It's such a great result for us. And also, I get lots of data from our provider, twice monthly at least. And the average weight loss stands at 6 kilograms at the moment. It is not a diet programme, it's a complete behavioural change programme. And right at the beginning, they talk and do group work around the psychological barriers to people actually making changes to their lifestyle. And I think this is really important because I know that everybody on this call knows what they should be doing, but are we all doing those things? So I think it's very important that we look at what are the barriers to people not stopping smoking, maybe what are the barriers to people making a few changes to the things that they eat and maybe reducing their portion sizes a little bit more. What are the barriers to people going out and taking a little bit more exercise? So you'll see the slide in front of you now. This is just another little example of how people who've gone onto the programme have really, really enjoyed it, but it's also been of great benefit. So this is Tim here. I mean, he's lost 4 stone. It's unbelievable, isn't it? And he thinks it's the best thing that's ever happened. And it was a true wake-up call when his GP referred him in. And you can read it for yourself there, that he's still young. I feel so fit and well now, and I've got my whole life ahead of me because of Healthier You. Are there any questions? Let me have a look in the chat. Do we refer these patients every year if they remain in NDH range? No, if somebody's in NDH range now, we would like you to refer people into the programme now so that they can start to reduce their risk of developing type 2 diabetes. You know that the QOF points, obviously, QOF has been stood up, and people with NDH are offered by primary care to go in for a review. Some of those people may well go on to have developed type 2 diabetes. So we've already talked about some of the projects and the programmes that are suitable for those people. But if somebody is still in NDH range, then please, we'd like you to refer into the prevention programme. And as the animation said, if you refer into the prevention programme, you can also count that towards the weight management enhanced service specification. So your practice will receive £11.50 for referring into this programme. So that's something that we would like you to do. But we are repeating these every year. Many remain NDH. Yes, that's it. So please just refer them in. Do we refer on the basis of one blood test in NDH range? Yes, so the person has had to have had a blood test in the last year. It was extended, the time frame, because of COVID, but we've reduced it back down now. So if they've had a blood test in the last year and it is still in the NDH range, then please refer them into the programme. Let's say it's still not face-to-face as per COVID. Is this still the case? So we were asked by the national team to stand up resumption into face-to-face programmes. So at the moment, we've got face-to-face programmes running with remote programmes. So the remote programme is through Teams or on the phone, plus we've got the digital programme. When by the end of July, we will have very specific remote programmes, so that will be through Teams or through the phone for certain populations. So it's those people who need a programme in a community language, those people who are deaf, those people who have visual impairments, but also women who've had GDM at any time but are now in normal range, because we want to get those people in a group together. And there'll be quite a lot of young mums there, some people who've probably got a few children, and so it gives them more flexibility either for them to do the group-based programme online or to do the digital programme. Is there anything else anybody would like to ask me before I hand back to Ewan? No? So you will get the slides. It will have the link in. You can have another opportunity to look at the animation, and you will be able to share that with your colleagues back in your practice. We are doing more animations. We're doing some in community language and languages, and they are patient facing. When you say prevented, what time period is the data referring to? So it was over a 2-year period. Over a 2-year period, they looked at people who'd been on the programme and subsequently had HbA1c checks, and they'd stayed well below the threshold for NDH. Okay, Ewan?
Thanks very much, Krista. My final slide will have contact details for all of our team at the SCN. So you're welcome to email us after today, once you've had a look at the slides, if there's any more specific questions. We are involved in quite a lot of other work, for instance, as well as the projects we've mentioned today. Greater Manchester is one of the initial 10 pilot sites for the low-calorie diet programme, and we are tasked with generating 750 patient referrals into that. We are sort of well on the way with that, and again, if anyone's interested in that, we can give them more details. We're also conscious of the impact of the COVID pandemic. I mentioned previously the NDA dashboard. There is another dashboard on the same site, which is the COVID recovery dashboard. And you can see from this slide the number of patients completing all 8 care processes in the period January to September 2019 compared to that in January to September 2021. And that's broken down by CCG. Again, on this dashboard, which anyone who's got access to the future NHS platform can link into, you can drill down into CCG and PCN and practice level data. So we are in the process of developing a COVID recovery project, which is funded by the national team. We'll be providing, for those that need it, because the system is different in different CCGs, risk stratified search functionality to all primary care practices and GM, where you can look at who are the highest risk patients that need to be seen most quickly. We'll also be putting funds into supporting the practices or PCNs with the lowest level of care process completion, particularly around HbA1c. Supporting them with finance which can be used to either employ HCAs or backfill. We'd want to be as flexible as we can with that. So that's a project that we've got ongoing, which if people are interested in, again, we can give you more information and more details. Accessing all this data that I've been talking about can be done through the future NHS UK platform. If you're not registered, you just need to ask for registration and you'll be given it working for the NHS. And when you do that, you ask for access to the diabetes workspace. That will take you to a site which I've done a screenshot of there. You don't need to worry about the banner saying it's under development. It's all up and running. And there's a data hub link, the big bar at the bottom, which you can click onto, and you can access all of these dashboards directly. If you need any more information from myself or any of the team, we've got details down there. One of them, Natasha's quite new, so we're still waiting for a mobile phone for her. But other than that, you've got emails and phone numbers for the SCN team. And if you need it, we can link you into GP Excellence and to Lisa and Anne as well. So in terms of the time that we had available, I think we're just about there, but we've got time for a few other questions. And really another sort of offer to you when you get these slides and you have a look at them. Have another look at the governance diagram that I mentioned earlier and look at the steering groups. Leslie has very kindly linked me in with a couple of your colleagues who we're going to engage in some of those steering groups. But if you've got an interest in any of those areas, prevention, structured education, multidisciplinary foot teams and lower limb care, diabetic inpatient specialist nursing, or a sort of wider treatment and care, which includes the COVID recovery and other projects. If you've got an interest in being linked in or being involved with any of those, please do let me know. Other than that, Leslie, if you think there's anything I've missed, Leslie is a member of the Diabetes Board. So happy to pick up on anything you'd like me to add, Leslie, or to answer any questions in the couple of minutes that we've got. Thank you.
No, that's really good, Ewan, and thank you to everybody for coming today. I think we all know as nurses how important education is for both our patients and for ourselves and for our professional development. So thank you for thinking about us really and asking us what is suitable for us, because sometimes we don't even get asked, and I'm sure my colleagues here have said that in the chat to you, that it isn't often that we get asked what is the best time for us or what is the best day, or how much notice you need to give, and it is difficult to get to those sessions. So thank you for that, and I'm sure there'll be a lot of interest in the programme as well. And thank you for showing us just what is available for our patients and how we can improve diabetes going forward. If any nurses that are listening here today or are listening or are watching back the recording and want that information about who to get involved, Ewan, they can contact me and I can send their details on to you rather than it blocking your inbox. Everybody will have our contact details at Primary Care, so we can send that on to you. And I urge you all to get involved, because it's really good. If this is your interest, come and get involved and make a difference for your patients. Lisa, you've got your hand up there.
Thanks, Leslie. Can I just jump in quickly? I put a question in the chat, actually. If people want to respond in the chat, that's great. You just need to scroll back a bit now. It's disappeared. Just to ask, because we're curious, if people were to attend a half-day session, would the offer of backfill funding be more attractive to them being able to do that, or does it not really make a difference in practice nursing? That would just be helpful for us to know, because that's something else we're considering as well as an option. So if people want to just respond to that in the chat, we'd be grateful if people don't mind.
Yeah.
Thanks, Leslie.
That's fine. Yeah, if you'll just respond to that in the chat, and then it can be picked up if that does make a difference for you getting out to get training and education. So thank you very much, team, and hopefully we can invite you back, and we can have an update on those things as well, and see how things are going with the training programme and the Health UU and Diabetes My Way. Thank you very much. Thank you.
Thanks, Leslie.
Thank you. So we're going to move on now. I know we're waiting, people are waiting in the wings to be moved over to their chosen breakout rooms for the sessions that you've chosen. If you haven't previously requested a breakout room, you'll probably stay in the main room, and Claire will be able to put you in one of them of your choice at the end. So we'll come back to the main room after the breakout sessions. So Claire, if you can do your magic.